This session is about snoring and sleep apnea syndrome in brief. So in this we are going to discuss about the definition, etiopathogenesis, pathophysiology, clinical features and management of sleep apnea syndrome. Some definitions: snoring is an undesirable sound produced during sleep, and apnea, as all of you know, it is a cessation of respiration. Now, what is this sleep apnea? It is a cessation of breathing lasting for at least 10 seconds during sleep. Now, there is one more entity called hypopnea, where there is reduction of airflow as suggested by the term itself, but it is considered when 50% of reduction of the airflow occurs, or there is 4% of drop in the saturation of the oxygen. There are some indices here. One is the apnea index, that is the number of episodes of apnea in 1 hour. And apnea hypopnea index, or API, also called respiratory disturbance index, that is RDI, is the number of apnea and hypopnea episodes per hour. So when you add the apnea and hypopnea episodes in an hour, that is called apnea hypopnea index API, also called as RDI. This is important when we define a sleep apnea syndrome, which is defined as the 30 episodes of apneic attacks in a 7-hour period sleep, each episode lasting more than 10 seconds. That is the definition of sleep apnea syndrome. I already told that about snoring, that is the unpleasant sound produced during a sleep. Why this snoring occurs? When we breathe against resistance, that causes vibration of the soft palate and the pharyngeal structures like tonsils and the base of the tongue. So this snoring may be associated with OSA, that is obstructive sleep apnea, or it may not be associated with the obstructive sleep apnea. That means if a person is sleeping and is snoring nicely, doesn't mean that he is having a sound sleep. He may be actually having a disturbed sleep, in fact. So, what is this sleep apnea syndrome and what are the types of this sleep apnea syndrome? Sleep apnea can be classified as obstructive when there is collapse of the upper airway causing reduced airflow. So, that is called obstructive sleep apnea syndrome. But it may be central where airway is patent, but there is no signal from the brain. There is failure of signal from the brain. That is called central sleep apnea syndrome. Some patients will have both the types when it is called a mixed sleep apnea syndrome. So, what are the causes of obstructive sleep apnea syndrome? In this class, we'll be concentrating only on this obstructive sleep apnea syndrome. The causes may lie anywhere in the airway, starting from nose to the larynx. In the nose and the nasopharynx, the obstructive lesions like adenoid in the nasopharynx, deviated nasal septum as it is seen in this picture, uh, hypertrophy turbinate here as it is seen in this picture, a nasal polypi. Sometimes even a simple nasal valve collapse also can cause a significant obstruction to the airway, causing obstructive sleep apnea. Here, this is a picture showing a completely obstructed nasopharynx by the enlarged adenoids, and this is the picture of a baby with the adenoid hypertrophy, that is typically called as a adenoid facies in the oral cavity and oropharynx. So, as seen in this picture, a large tonsil, whether it is inflamed or not, a large tonsil can cause significant obstruction to the airway, causing obstructive sleep apnea. It may be a long palate, and the uvula also can cause sleep apnea and snoring. A large tongue, bulky tongue, causes also called macroglossia, causes significant obstruction to the airway. Sometimes a structural anomaly is like retrognathia, when the mandible is resided, it can cause obstruction to the airway by compromising the space in the oropharynx. The causes in the larynx and hypopharynx. A condition like laryngeal stenosis, either congenital or acquired post-traumatic, overhanging or large epiglottis. A large epiglottis can be one of the causes. A cyst in the vallecula, as it's seen in this picture, large cyst in the vallecula can be one of the cause of obstructive sleep apnea. A laryngeal mass or a laryngeal papilloma, a mass in the larynx, can also cause obstruction to the airway, leading to obstructive sleep apnea. Some other causes may be obesity, short, bulky neck, and certain conditions like alcohol, heavy alcohol intake, and sedatives and hypnotics can be the causes of obstructive sleep apnea. Now, pathogenesis of obstructive sleep apnea. So, what happens when there is occlusion of the oropharyngeal airway? It results in asphyxia. Of course, when there is obstruction of the airway, there will be asphyxia, and this asphyxia will continue until there is a brief arousal from the sleep. If the asphyxia continues, suddenly patient will wake up, and when the patient wake up, the airway pattern is restored and the airflow resumes. But again, after some time, when the patient goes to sleep again, the process is repeated and the sleep become fragmented. The physiology here is during wakefulness, the upper airway muscle activity is greater than normal to compensate for the airway narrowing and high airway resistance. That is why during daytime patient may be comfortable, but at night his sleep is severely disturbed. Now, what happens if the patient gets OSA and if his sleep is disturbed? The frequent arousal automatically causes excessive daytime sleepiness, because even if the patient has slept for 7 to 8 hours, his sleep quality is not that good, and this in turn cause disturbance in the memory, and apnea causes hypoxia and retention of carbon dioxide. This leads to physiological changes like congestive heart failure, bradycardia, left heart failure, and sometimes arrhythmias. That is why unnoticed obstructive sleep apnea can be one of the cause of silent death. When we evaluate a patient with obstructive sleep apnea, history is most important, and this history should be taken also from the family members, because the they are the ones who will be observing, who will be witnessing his snoring as well as the arousals. One important interesting scale is the Epworth sleepiness scale, to have an idea of how his sleep is disturbed. So in this there are certain situations, and the chance of dozing during these events are marked from 0 to 3. Like the situations are sitting and reading, watching TV, sitting inactive in a public space, as a passenger in a car for an hour without a break, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after lunch without alcohol, in a car while stopped for few minutes in a traffic. This in fact when he is driving. The chances are graded as 0, no chance, 1, slight chance, 2, moderate chance, and 3, high chance of dosing. So this is the score given to each of these situations, and the total, if it is less than 6, then that means the patient is having a good sleep in the night. If it is 7 to 8, the sleep quality is not that good, it is more of an average. And if it is more than 9, patient needs consultation and evaluation of his sleep. Now, what is this evaluation? So, evaluation starts with a detailed head and neck evaluation, including the diagnostic nasal endoscopy and nasopharyngoscopy, body mass index, and collar size. This is important because I already mentioned obesity as one of the cause, and also short neck. So, this can aggravate the existing structures, compromised structures in the oropharynx. Muller's maneuver is a method where the nasopharyngoscope is passed into the nasopharynx and patient is asked to breathe in with the nose and the mouth closed. So whenever the patient breathes in, there will be collapse of the airway which can be visualized with the nasopharyngoscope already kept in the nasopharynx. Radiological like X-ray cephalometric uh, assessment. So the cephalometric assessment give an indirect evidence of a compromised airway, though they are not the witness for actual obstructive sleep apnea. CT scan is another which can give a picture of a static obstruction, but there is one entity called dynamic MRI which can actually detect the changes in the airway which happens during sleep. Gold standard for obstructive sleep apnea diagnosis is polysomnography. I'll be discussing in detail in the next slide. And next is the drug induced sleep endoscopy. So, what is this polysomnography? Poly means many, somno means sleep, graphy means recording. So, during sleep, certain vitals are recorded like EEG, electroencephalogram, electrocardiogram, electromyogram, electrooculogram, saturation of oxygen, nasal and oral airflow, sleep position, blood pressure, and in some instrument even the esophageal pressure. There are multiple parameters that are assessed, and based on this the polysomnography is graded as class 1, class 2 and 3 class 3, where class 1 has a multiple parameters. 24 parameters are assessed during this polysomnography. So with this, the patient's quality of sleep is assessed during night. The at least 6 hours sleep is required for diagnosis of obstructive sleep apnea using a polysomnography. If you want to see what happens during sleep, you can do a endoscopy, but it is not useful if it is done during or when the patient is awake. Induce sleep by giving certain medicines like midazolam or thiopentone, and during sleep, pass an endoscope, flexible endoscope through the nasal cavity into the nasopharynx and larynx and observe the changes that is happening when the patient is actually sleepy. So this is an indirect method where you are inducing sleep and observing the airway. So now you have confirmed the obstructive sleep apnea by polysomnography, and also you have done an endoscopy to see what are the structures responsible for sleep apnea. Now, based on this, we have certain treatment modalities. All patients are not treated with a single modality here. Some patients may require only slight change in the lifestyle. If a patient is obese, then just changing the lifestyle can itself help the patient in reducing the weight, and he may get rid of his sleep apnea. There are certain positional therapies where you ask the patient to change the position and sleep in certain position. There are some intraoral devices, of course, they are not much useful, but the tested and proven effective are the CPAP, continuous positive airway pressure devices, which help in keeping the airway patent. CPAP is a time-tested devices, a non-surgical modality. But when we come to surgical modalities, again there are nasal surgeries like correction of nasal septal deviation or removal of the nasal polyp or surgeries for nasal polyposis, and oropharyngeal and nasopharyngeal surgeries like tonsillectomy and adenoidectomy, and some oropharyngeal extensive surgeries like uvulopalato-pharyngoplasty. I'll show in the next slide. And the tongue, tongue is bulky, it can be reduced by certain methods. I'll show you one slide on that. And some skeletal surgeries like advancement xenioplasty and maxillomandibular advancement osteotomies done generally by a maxillofacial surgeons are the surgical options available. Here, this patient has a compromised oropharynx. You are taking out the uvula and the soft palate and making a oropharynx roomy. Here, this patient has a bulky or compromised oropharynx, bulky tonsils, bulky soft palate and uvula. Everything is taken out and it is sutured. This can be done by cold knife or laser assisted. So this is called uvulopalatopharyngoplasty, and of course this is one of the indication for tonsillectomy. And the tongue base reduction, a bulky tongue which is reduced, a middle portion of the base of the tongue is reduced by a cobbler or radio frequency cautery, and by reducing this you are improving the airway in the oropharynx. These patients may require temporary tracheostomy, because there will be chance of edema in the postoperative period and patient may collapse. So that is why a temporary tracheostomy is performed always when you perform a tongue-based surgery. So when I say tracheostomy, if nothing works, tracheostomy is the ultimate treatment of choice for obstructive sleep apnea, because it bypasses the entire upper airway and patient is breathing through his neck. That's about the obstructive sleep apnea. Thank you.